All right, so I was already prepped for Takotsubo's by Harmony, so we'll just get into this case. So this is a 70-year-old woman who presents with chest pain and shortness of breath, has a history of hypertension. And all her symptoms started recently, but this presentation to the hospital was 2 days after her son died from COVID. Her physical exam was unremarkable aside from maybe a displaced PMI, but her vitals were fine. She looked a little bit uncomfortable on exam. And this was her EKG that you can see here. Some ST elevation in V1, V2, but it's less than 2 millimeters, but diffuse T-wave abnormalities throughout her precordial leads and in her inferior leads. So when she was seen in the emergency room, her troponins were elevated. And while they were, I don't know what they were exactly waiting for, but for 1 hour they repeated them and the troponins did increase. The the cath is shown here, and she had normal coronary arteries. So here is her echo, which was done actually after the cath. So you can see very typical Takotsubo's appearance with hyperkinesis at the base and hypokinesis. Sorry, it moves faster than me. It'll come back, but hypokinesis at the base. So no further imaging was actually done in this specific patient. She was discharged home after 2 days and was told this is not a heart attack, and that the heart would go back to normal in a few months. She was given no medications, but she was given an order for a follow-up echo in 3 months and told to follow up with her primary care physician. So I think for all of us, we know Takotsubo syndrome, and it often has preceded by an acute stressor, usually an emotional stressor, but also can be a physical stressor. If it's an emotional stressor, it can be both positive or negative. And it's identified to be, it's at least postulated to be induced by a catecholamine surge resulting in this myocardial damage. There are some sex differences. This is the one of the conditions that has a very uneven sex distribution, really a ratio of 9-to-1 for female to male. And for women, it's found, at least by registry data, that it's more commonly in an emotional setting compared to a physical trigger, which is seen more often in men, as neurologic specifically more seen in men, and psychological disorders. And it is particularly common after menopause in women, but the role of sex hormones is not well understood. So the workup you actually already saw, I think on the other presentations, Dr. Reynolds showed this as well, that the workup should involve after a cath, deciding, okay, if there's no blockage, what do you do next? And then cardiac imaging with cardiac MRI to rule out other causes like myocarditis. And obviously, Takotsubo's, if you have the echo in advance, you might have already a predisposition to think that it's Takotsubo's. But there is Takotsubo variants other than the one that's classically described where the name originated from, looking like the pot that is used to catch octopi. So that's the classic, the typical one. That we see the ballooned left ventricular apex, but the atypical ones you can see here, mid-ventricular and the other ones that are seen, but sometimes not easily recognized that this is Takotsubo's. Happens more frequently in younger people. Usually the ejection fraction is not as significantly reduced, but in terms of outcomes, in terms of specifically mortality, there's no difference if you have the typical versus the atypical. The pathophysiology is still not well understood, although I'll show you some of the hypothesis behind it. And there was a really nice review that is, this figure to the left came out from a paper that was just released 2 days ago. That also was a really nice review, and there was one recently in ESC journal, the European Heart Journal as well. So the first reported case was in 1990, and then the same authors wrote a case series that was published in 1991. And in that case series, they at least hypothesized that this was due to microvascular dysfunction and coronary artery spasm. And these reversible defects this is how they were commonly described, that they were reversible, but it may be due to microvascular dysfunction that was occurring. Some people have also asked, could this be spontaneously dissolved occlusive thrombus? And the reason that we think that that's an unlikely hypothesis is because now in cohorts that have looked at this, when they've done IVUS, they've not seen any evidence of thrombi. So we don't think that. And additionally, it is usually not in a single vessel distribution that can be explained by a thrombus. So the proposed mechanism is that either an emotional or physical stress occurs, then norepinephrine and epinephrine get released. They both have different targets in the heart. So at the base of the heart is the norepinephrine, where norepinephrine particularly binds. And at the apex of the heart is where epinephrine has its effect. And that's why the classic version is hypothesized to be at least triggered by catecholamine surges. It doesn't explain entirely everything. A lot of these patients will not have elevated heart rates or blood pressures despite this supposed effect of the catecholamines. But this connection between the brain and heart is well established. They've done studies where they assess the neurologic system at the same time and see increased metabolism and increased blood flow at the same time. So we do think that that can be a driver in this disease, but there is patients who have had heart transplants, and we do not see, they don't have obviously they're cardiac denervated, and yet there has been reported cases of Takotsubos in a transplanted heart. So we use the additional imaging to help us look at what's going on, and I think that cardiac MRI and echocardiography have both been well described in Takotsubos. Early on, we used to just look at it in the hospital stay and maybe in one follow-up, but we have longer studies now where people have been following the patients out longer, and this particular image from a cardiac MRI shows damage compared to baseline at even 5 months, which is where that image is from. And there's concern about the prognosis of these patients. Not just because we see these changes, but just also because of the data. So we should talk about the elephant in the room, or the octopus in the jar, if you will. Is Takotsubos really benign? Because that is often how it's presented to our patients. Well, we know 15 to 20% of patients with Takotsubos will actually have changes in their cardiac function that result in reduced quality of life and also in cardiac complications. There's also an increased rate of major adverse cardiovascular events, as well as an increased rate of all-cause mortality. And in the acute in-hospital phase, I think people underappreciate that the rates of mortality approach 5%, which is no different than an acute myocardial infarction. 10% of these patients will have recurrent Takotsubo's cardiomyopathy, and some will be the patient who's completely asymptomatic. Others will be the people with recurrent symptoms. So there's no way to predict, and it's also not based on improvement in left ventricular ejection fraction. Another important piece of information that I think people underappreciate is the rate of stroke. In-hospital stroke is reported to be as high as 2%. And this systemic thromboemboli is probably from some mural thrombi, given that the left ventricular function is so dramatically reduced. But we don't at this point recommend anticoagulation. And this is much higher than we'll see in acute coronary syndrome. So you can see from different prognostic scores, this is the Intertac prognostic score, the Mayo has also a prognostic score. This tells us who's going to do bad and who's going to be okay. The green line, if everybody was the green line, then we could say that there's nothing else to do. But for people that have any of these adverse prognostic markers, they are the people that are more likely to go on and have adverse events. Now, what can we do about it? Right now, we don't entirely know, but not following up on them and looking for progressive signs is also concerning. So there is a lot of unanswered questions in Takotsubo's rather than answers, and this just gives us an area that we need to focus on. We don't really know the underlying pathophysiology. We're hypothesizing for a lot of this. We don't know why some people get it and why others don't, because we all have emotional stressors. So is it genetic? And why is the left ventricular dysfunction so bad that if that had occurred in a myocardial infarction, most likely they would have died or had dangerous arrhythmias, and yet we don't see the same pronunciation in these patients? So there's something about this disease that is different. And why does it affect women so disproportionately? We also don't know. And again, the mechanism of recovery and who recovers, we don't have answers for. We need, of course, more information about how we can make this diagnosis quicker. Of course, we expose these patients often to acute coronary syndrome medications because they present like a myocardial infarction. And we don't know for those who present specifically with shock, is also the group that has worse outcomes, what unique treatment should they undergo. We just do supportive care at this time. Our treatment, we don't entirely know, obviously, for this group. And then diagnostic strategies to particularly identify who's at greater risk. We don't know if it's those people only with a cardiac MRI of fibrosis. Is that enough? Is that pointing to the person who will do worse? Because it's not clear that those are the only ones that do poorly. There's other ongoing work in Takotsubo's as well. The role of estrogen is of interest because it does occur, obviously, in menopausal women more frequently. And then also in patients with cancer. Patients with cancer often can present with Takotsubo's syndrome, and we don't know why those rates are higher in that particular group. There's work also being done on identifying genes that might be associated with this, and maybe that's what's predisposing certain people to get it. But again, those answers are still not fully clear. But all these great registries that are out there for Takotsubo's hopefully will help us answer some of these questions. Again, the cardiovascular abnormalities, we still need to identify, is fibrosis the marker that we should be focusing on, or is it something else? And treatment, there's two trials going on that I'm aware of, NACRAM and Broken Sweetheart, and maybe they will help us identify unique treatments for this group. So just in summary, again, this is a disease that disproportionately affects women. It can affect postmenopausal women and accounts for actually 10% of their presentations with acute chest pain. A high mortality rate that I think is underappreciated in our cardiology community. 20% are left with persistent left ventricular abnormalities that we don't entirely know what to do with, and I don't think always get dealt with. Survivors can continue to have recurrent symptoms and adverse outcomes that are underappreciated. To date, we have no treatment for those to prevent a recurrence and no established treatment baseline after they have an event. So an area that we really need to focus on and do more work. So thank you.
Thank you. All right.